Okay, thank you so much for that introduction, and thank you so much for inviting me to this amazing conference. So, just to reiterate, I'm going to be presenting more information on postoperative ileus that you've heard some about today, about the comparative pathophysiology more, and then potentially some future therapies that we might consider for horses. So, in general, for postoperative complications, these are the ones that we might consider, and this was published back in 2002. They're still fairly accurate. They are a number of inflammatory postoperative complications, including endotoxic shock, colitis, diarrhea, peritonitis, incisional infections. Sometimes we get clotting of the jugular vein as a consequence of inflammation. Repeat colic after surgery is perhaps the most common postoperative complication. And then the one we're going to be dealing with most on this presentation, postoperative ileus, which is a dysfunction of the gut so that gut contents do not pass down the gastrointestinal tract normally. So clinical features of postoperative ileus, I think you're all fairly well aware of, but this picture on the left shows a classic postoperative patient with some signs that include ileus. So you can see this patient has traumatized itself somewhat in the way that it's rolled with the pain from colic, and it has had a small intestinal resection. And then this is the next day after surgery, and you can see it's on IV fluids and being worked on here because it's developed excessive fluid in the stomach as a result of the fluid not passing down the gastrointestinal tract correctly. And so we've passed the stomach tube, and as you can see, there's some fluid in this tube, which we're going to retrieve to make the horse more comfortable and to make sure there's not something really severe like a gastric rupture. And then in terms of how do we define nasogastric reflux? We usually detect it in horses that show some evidence of pain, although you can see this horse again on the left is more depressed. Typically, we'll detect an elevation in heart rate and perhaps other signs of shock, such as increased packed cell volume or hematocrit. And then when you pass a stomach tube all the way into the stomach, you get a free flow of fluid. And it has certainly been debated, well, how much fluid is it for it to be postoperative ileus? So normally in an equine stomach, you wouldn't expect to retrieve any fluid at all. So most sources would say greater than 2 liters. And some sources would say more than 2 liters on one or more occasions, and then you'll see other definitions. But to some point, the consideration is there's excessive fluid in the stomach that freely flows like this, and that's the main diagnostic criteria for a horse that has ileus. And then this picture on the right here is just to show some other evidence that you might see that the horse has endotoxemia. So this horse has discolored gums and will have had an elevated capillary refill time. So the symptoms of shock and postoperative ileus sometimes all go together. This is a slide showing a survey that was conducted in Europe by Dr. Lefebvre and her group from Dr. Hudson in Scotland. And they subsequently repeated this in the United States, and it had similar results. So I thought I would just show you this because this is just asking veterinarians how much they estimate postoperative ileus to occur in their patients. And so the estimated incidence was anywhere from very little, 0 to 10%, all the way to some practitioners, some veterinarians felt they were seeing it in more than 50% of their cases. But you can tell that typically after a colic surgery, and more so after colic surgery with small intestinal resection, it tends to be in the 11 to 20% range. And that's fairly accurate. And that's good to know these figures from other practices so that if you feel like you're having a particular problem in your practice, you can then compare and then ask questions about why you may be seeing more of a problem. And then this gets to this chart on the right. It talks about the differences in definition, which I don't want to be confusing. The reflux volume at greater than 2 liters at any given intubation was actually that was the place where I started when I started researching this area. And then you can see there are other levels that people have said, well, maybe 2 liters is not that much. Maybe it should be more than 4. Maybe it should be more than 2 on repeated intubation, more than 20, and greater than 8. And it makes it a little bit difficult to look at the different studies and compare them, because once you've picked one of these categories, that's essentially how you will define postoperative ileus. But I think you can see that most people feel like somewhere around 2 to 4 liters on one or more occasions would define a case of postoperative ileus. And again, remember why you're passing the stomach tube in the first place. You're passing it because the horse had signs of colic potentially after surgery, or showed signs of an elevated heart rate, and then other signs of shock, and that led you to pass a stomach tube. So then in terms of evaluating, well, then what puts a horse at risk of postoperative ileus? And there've been several studies, and I'll show you a couple of the better ones, I think. And so this is one from Noah Cohn, who's in Texas. And so he's used statistical regression here to show which factors are most important. And when you look at these charts, when you see this naming here, odds ratio, it would mean when you read this number, 7, it means that a small intestinal lesion is 7 times more likely to have postoperative ileus than a horse that has a different lesion, like a large intestine lesion. So small intestine is then top, and that kind of makes sense because when we think about it, we're talking about fluid that's not exiting the stomach and going down the small intestine correctly. It doesn't mean the large colon is not affected. It is. It's just harder to assess. And the part that we see in the end is the fluid coming back from the small intestine into the stomach. The next factor that he found that was significant was a duration of surgery of greater than 3 hours. And that would be about 6-fold increased likelihood of postoperative ileus. And the duration, as you can imagine, is important because the longer the surgery takes, there's more surgical trauma, and it probably meant that the surgery was more difficult to accomplish, such as a resection and anastomosis. And then pack cell volume I mentioned before. So this means that the horse is in shock or is trending towards shock at greater than 40. And these horses are approximately 3-fold increased likelihood of developing ileus. And probably what this means overall is when a horse is in shock, particularly if it has endotoxemia or systemic inflammation, it's that much more likely to have inflammation in the intestine and slow it down. And I'll show you more about why inflammation slows down movement of fluid and motility. There were 2 factors that were not strictly speaking significant, but they added significance to the overall model that Dr. Cohen produced here. One of these was pelvic flexure enterotomy, so emptying the large colon at surgery. This is a low number, so this means this actually protected horses. And it has been debated as to whether at surgery, if the large colon is full and you have a small intestinal lesion, should you actually empty the large colon? For the most part, I wouldn't think about doing that, but certainly if the large colon was excessively full of fluid, then that would be a reasonable idea to try to prevent the backup of fluid into the small intestine, or to prevent the fluid that's in the small intestine getting down into the large colon. And then the other interesting factor that was somewhat protective in this study and has been debated a lot over the years was the use of lidocaine. So a local anesthetic or a nerve blocker, does this help to block nerves? And literally that would mean blocking enteric nerves or blocking something related to inflammation. Does it help? And in this case, intraoperative lidocaine, so using lidocaine while doing the surgery, and it would typically be continued after surgery, was somewhat protective. Here's another, a little bit more recent study with some other factors that I'll go through a little bit more quickly. So again, heart rate as an indicator of shock placed the horses at risk. The quantity of reflux, of course, that makes sense. So in this case, they used 8 liters, and this speaks for itself, really. If the horse has reflux, we would consider that it had postoperative ileus. And then small intestinal resection comes up again. And so importantly, when you keep thinking about this, it's the amount of surgical trauma and the complexity of the lesion and the amount of time it takes to do the surgical procedure. So the horses that had small intestinal resection were 6-fold higher risk of postoperative ileus. And then again, prophylactic lidocaine was significant in this case. And this is a totally different group. This group is in Belgium, and they showed that giving lidocaine intraoperatively was protective. So we have these clinical studies that are beginning to show actual evidence of lidocaine being effective. And I'm not going to show you all of those studies. So let's just go through the surgical risk factors a little bit more, because if we talk about, well, then how do we prevent postoperative ileus? We have to have some understanding of some of the interventions that we can take to reduce the risks. And so there are several lesions that I'm showing here, and several different reasons why they might develop postoperative ileus. So on the left here, this is an ileo impaction, which we heard about quite extensively earlier today. So this impacted ileum here, this in general, this is going to be tempting to squeeze this impacted material down into the cecum that's right here. When you press on this bowel or manipulate it to push it into the cecum, it creates surgical trauma. And to a large degree, surgical trauma is unavoidable. What we will do with more extensive ileal impactions is actually create an enterotomy higher up in the intestine, and then empty the intestinal fluid outside of the horse, and then put a hose into that enterotomy and use the water to push the ingesta, the impaction, into the cecum. And we do that because it's less traumatizing to the bowel to do that. And you have to make a decision on which way to do it based on the length of this impaction. This picture on the right is a small strangulating lipoma with a strangulated loop of intestine. So that's going to have to come out. So this will now be an intestinal resection and anastomosis. And then the bowel adjacent to it has some fluid into it. And generally, we will push that fluid out of the horse in the way that I just described, or you can push it through once you correct this strangulation, you can push it through the strangulation. But one way or another, when you push the fluid through the bowel, it does create some trauma. However, we find that it's more useful to get the fluid out of the bowel than to leave it in there. And then this is just generally distended intestine here. This is not anterior enteritis, but it's similar. It's just an obstruction further down that you can't see here, and it's obstructed the bowel enough that you can start seeing it's becoming discolored. So this fluid all needs to get pushed downstream. And again, it's best to do this with an enterotomy and to push that fluid outside of the horse. What we used to do is push all of this fluid downstream into the cecum, but it makes the cecum really full, and I think it creates a greater risk of ileus. And then the discoloration that you see here is creating some inflammation that's also going to be problematic in terms of creating ileus. And then this kind of shows, because it's blurred, that this is stripping the bowel to push fluid downstream. And it's just to highlight why there is surgical trauma there. We think it's necessary to push the fluid out, but nonetheless, it creates some trauma and inflammation to the bowel. And then I just wanted to show you this quick video here. So this is what I'm talking about. This was after a horse had a resection of an intussusception. And then I'm just pushing that fluid down out of the intestine, and that's going down into a bucket on the floor. And the reason that it's done this way is then there's much less resistance on the bowel to pushing that fluid. So although I realize I'm creating surgical trauma, the fluid is easier to push out of the horse and it doesn't go down into the cecum. So overall, then, pathophysiologically, how is postoperative ileus initiated? So it's initiated by the trauma of the surgery that I've shown you, the ischemia of the lesion, distension. So when you just have a simple obstruction like an ileoimpaction, it's still distended, and that still causes some discoloration of the bowel. And then the availability of lipopolysaccharides and other toxins in the bloodstream. And so these factors combined, what they do is they activate a macrophage network that's distributed throughout the intestinal wall. And once that macrophage network is activated, it signals to the neutrophils to come into the intestine. And those neutrophils are the primary inflammatory cells that actually cause the damage, that interact with the enteric nerves and the muscle to start to interrupt the correct signaling in the bowel in order for it to work properly. So these neutrophils activate inhibitory enteric nerves, and then they reduce contractility of the bowel. So in the end, it's really all about inflammation. And when you think about that, it makes you think about, how am I going to do this surgery to limit the trauma? I need to get rid of the ischemic bowel. I need to get rid of the distension, and I need to treat the systemic endotoxemia as well as possible. And there is one other part of the nervous system that is activated here, and that's the sympathetic nervous system. So this is a faster acting way to reduce contractility essentially through the sympathetic nerves that will initially tend to shut down motility. This happens quite quickly. But more often what you see is postoperative ileus taking quite a while to develop after surgery. So it may take 12 to 18 hours to develop. And that's because it's going through this inflammatory pathway that I'm showing here in the middle. There's one other piece of the puzzle that came from human medicine that explained that when you have a single point area of intestinal manipulation, so single strangulating obstruction or an impaction, why is it that that one small area seems to affect all of the bowel? Well, the reason is, so remember I talked about activation of these blue areas here are the macrophage network within the wall of the bowel. They activate dendritic cells that then activate T cells. And these T cells get into circulation, particularly the local lymphatic circulation, and they distribute inflammatory mediators to other parts of the bowel, including these inflammatory mediators would include nitric oxide and interferon gamma. So you have one area of inflammation and obstruction, activation ultimately of another population of white cells, the T cells, that then distribute inflammatory mediators across all of the bowel, And then you get this ileus that affects more than just the area that you were manipulating. This is a more complex picture, really trying to tie in every single factor related to postoperative ileus. So Dr. Emily Hellstrom was a graduate student in my lab quite recently, and I just wanted to point out a couple of factors here. So one is the gut handling that I talked about. That has an effect. And then I'm going to go through a little bit more detail from this gut handling on another area that we've been looking at. So remember, I've said that when you handle the gut, that causes trauma, and that it can cause inflammation. And that inflammation can then inhibit the nerves that are responsible for motility. There is an important part of the enteric nervous system that we hadn't paid much attention to until recently, and these are the enteric glia. And glia just means glue in Latin. So these are the cells that kind of stick the nervous system together, but they're actually cells and they actually have an effect on signaling to the nervous cells. So what happens after gut handling is that these enteric glia, we believe they're activated to cause an inflammatory response. And that is partly how the inflammatory response is caused. So in other words, not just by the macrophages, not just by the T cells that I showed you, but also these glial cells. And so the enteric nervous system itself is activating inflammation. And then there's a whole host of different mediators that are released. One of or more of these I've mentioned, like nitric oxide, that decrease contractility and then can cause other problems like edema. These other things down here are important too, and I'll mention more when I get to the treatment. So intravenous fluids are important to regulate properly, and then other drugs that are used can have an effect on postoperative recovery, and I'll mention them in more detail later. So we've done some experimental work to show evidence of what we would call neuromuscular inflammation. And in this case, what we've done is artificially clamped off a section of intestine here on the left, clamped off the blood vessels, and then we leave it for 2 hours. And you can see it discoloring here. So it's effectively becoming strangulated. And then at the end of the 2 hours, we release the clamps, and this is what you have left. So it's still discolored, although over time it will regain its normal color. So it's injured, but it's not injured to the point that it needs to come out of the horse. And then we can look at the intestine or run experiments on treatments to see what affects this inflammation here in this piece of bowel. And so I just wanted to show you what the inflammation looks like. So just even from manipulating the bowel, when we look at the serosa, which is what this is normal serosa out here on the left. This is normal bowel 18 hours after we did the surgery. So this wasn't strangulated, it was just manipulated. And these are all neutrophils here that are starting to replace the cells on the outer edge of the serosa. And some of these neutrophils are going down deeper into the serosa. And then you see more neutrophils if the bowel was made ischemic for 1 hour. And then, as I mentioned in that picture, we did it for 2 hours. And then this becomes a lot of neutrophils throughout the serosa after this 18-hour period. This also, by the way, contributes to adhesions, which is another major postoperative complication. But I'll show you more inflammation as you go down through the layers of the bowel. So the next layer in is the longitudinal muscle. This is normal bowel here, and you see a couple of neutrophils. What the neutrophils do is they tend to move in down these septa or gaps between the muscle fibers. So when the bowel was ischemic for 1 hour and recovered for 18 hours, You see more neutrophils coming in between the muscle fibers here. And then in this 2-hour section here, we've additionally stained for calprotectin, which is a protein in neutrophils. And so all the brown staining just highlights all the neutrophils infiltrating the muscle. And you can actually even imagine then, just from the manipulation and ischemia with the neutrophils in the muscle, they're creating inflammation and making that muscle work more poorly. The next layer in would be the myenteric plexus, and this is pretty important, of course, because this is the enteric nervous system. This is actually a proximal resection margin from a horse that actually had a piece of bowel resected at surgery, and we looked at it histologically afterwards. And the brown staining, again, is the calprotectin for neutrophils, and you can see some neutrophils adjacent to the ganglia here. So these neutrophils get right up against the neural ganglia and interfere with their function. And experimentally, after the 2 hours ischemia and 18 hours recovery, you see that there are a lot more of these neutrophils here in this experimental model. And you can imagine them impacting the function of these ganglia. And then the next layer in is circular muscle, very similar to what I showed you for longitudinal muscle, where out here at 2 hours ischemia, 18 hours recovery, there's a lot of neutrophils coming down through the septa in through these muscle layers here. And so if we graph this out, what we see from the both the manipulation alone, which is the black, the control, and then 1 or 2 hours of ischemia, and then recovery for 18 hours in these horses, there's a lot of neutrophils in the serosa, in the longitudinal muscle, and it almost looks like the inflammation is coming from the outer surface of the bowel down in through the muscle, in toward the myenteric plexus, and then all the way into the submucosal plexus. Of course, when you squeeze the bowel, the neutrophils can be coming from the other direction, in from the mucosa, in toward these layers. And we don't know which way they go, but it looks like a lot of them are being driven from the outside. And so one thing that we do to try to reduce trauma of the bowel is put in carboxymethylcellulose into the abdomen to make it more slippery, so we're not creating so much damage. So treatment of postoperative ileus would include use of intravenous crystalloid fluids such as lactated ringers. And there's been quite a bit of debate, particularly by Dr. David Freeman at the University of Florida, on how much fluid we should use. Because I think you notice in a lot of your postoperative patients, some of them, we hydrate them very aggressively, perhaps too much. And then there's a concern of whether or not there's increased fluid within the intestine or increased edema of the intestine. I think the most important thing to do is to treat them sensibly for what they actually need. Maintenance fluids is 50 milligrams per kilo per day. So for the average 450 to 500 kilo horse, it's about 1 liter per hour. And so that's a starting point. There's some debate that when a horse is off not being fed, that the maintenance level is lower, but I would still use this level. And then you have to gauge the ongoing loss of reflux. So if they're refluxing 10, 20 liters, that's going to increase the flow rate to 2 liters an hour. And then the other thing you have to consider is the level of shock. And it would be a mistake to undertreat shock to try to prevent too much fluid going in. And what I mean by that is you have to constantly monitor the pack cell volume, the total protein, the heart rate of the horse, gum color, refill time, because it's much more important overall to adequately treat shock than to worry about how much fluid might ultimately get into the bowel. Non-steroidal anti-inflammatories are typically given, and the one most commonly used, at least in the US, is flunixin-meglumine. And we've shown a reduction in inflammation if this is particularly if flunixin is combined with lidocaine. And then as far as prokinetic medications, meaning medications that might help motility, I've mentioned lidocaine. What it's really trying to do is reduce the inhibitory nervous system from preventing motility, but it's also some evidence that it reduces inflammation. And so here's the dose for lidocaine. It's given as a loading dose of 1.3 milligrams per kilo intravenously. And then you have to immediately follow it because it has a very short half-life with a controlled rate infusion of 0.05 milligrams per kilo per hour. It's not a mistake to just start the CRI immediately. If that's some people just immediately start with 0.05 milligrams per kilo, and it will get up to the therapeutic concentration quite quickly. And then you read about a lot of other drugs, which I've tried all of these. None of them are particularly effective, and certainly I could take questions on any of them. Metoclopramide I might mention because if you, one particular area that's most effective is right at the gastroduodenal junction. And so if you had a horse with gastric outflow obstruction or a foal, particularly with that, sometimes we'll try a different drug like that. And sometimes, to be honest, when you're really struggling with a horse with postoperative ileus, you will start trying some of these drugs. But the thing to consider is if your medications are not working and the horse is not doing well, particularly if it has signs of colic, unresolved shock, and it keeps refluxing, one of the best things to consider is to go back to surgery. Some owners won't want to do that, but it's certainly a consideration within the first 48 hours or so to ask yourself, should I go back in there and look and see what's happening? As far as the lidocaine, we did do one study where we showed that it had some anti-inflammatory effect. So this is a little bit of a confusing graph, but this is the number of neutrophils in the wall of the intestine. This is horses that have had in the white bars. If you just look at the white bars, they've had the 2 hours of ischemia, 18 hours of recovery that I showed you before, and they've been treated either with just saline plus flunixin, so fluids plus flunixin and lidocaine, and then lidocaine and flunixin. And so actually you see the greatest reduction in inflammation with the lidocaine and flunixin. There is a story behind why this flunixin causes a little bit increased neutrophil infiltration. But when you use the two together, it tends to reduce the total number of neutrophils. I wanted to show you this study out of the United Kingdom from the group at Liverpool that Dr. Archer runs. And so this would actually argue against the use of lidocaine. This is retrospective, and she's now doing a prospective study, which will give us a lot of information. But it shows these are survival curves. So one is like a horse that survives, and then all the way down to this is only about 60% surviving. So this is horses with small intestinal lesions, and it shows you their survival over time. So this is in days out here. So 800 days is several years. And you can see the survival dropping on these horses, but mostly they're saving about 80% of the horses, and most of them do pretty well for the first 1 to 2 to 3 years, and then it starts dropping off a bit. If the horse had postoperative ileus, the survival drops fairly dramatically. So you can see even within the hospitalization time, the survival is starting to drop down more towards 60%. And then as you see their discharge, it levels out to about 50%. So certainly postoperative ileus has a very big impact. And then if you look at the probability of survival, whether or not they got postoperative lidocaine, which is up here in the red line, or excuse me, no postoperative lidocaine, red line, or postoperative lidocaine in the blue, there was no difference. The problem with the retrospective study is that the horses that were more of a problem were probably more likely to get lidocaine, so there was probably some bias. But if she's doing this as a randomized controlled trial, so then she'll be able to tell really, does lidocaine make a difference or not, which will be very helpful. I just wanted to show you some other data here that we've been working on related to the glial cells that I mentioned. And so these glia are these cells that, as again, they kind of glue the enteric nervous system together. When these glia are activated by inflammatory mediators like interleukin-1 beta, they will then release their own inflammatory products. And in this case, I'm showing the barrier itself of the bowel. So to the degree to which these are the enterocytes that line the gut. And the thought process here is if the glia, they may be causing neural inflammation, which is problematic, but they may also be causing the bowel to leak. So they may be acting with inflammatory mediators on these enterocytes and allowing bacterial products in. And so then, and there was also a question then on the next slide, well, then if the glia are involved and interleukin-1 beta is particularly involved, is there something we can inject into the bowel to prevent inflammation that's induced by these glia? And the intervention that we tried is serum. And the reason we did that is it's like the orthopedic biologics that inhibit inflammation. So serum would be somewhat similar to IRAP. And so the idea is to put a biologic into the bowel that can potentially prevent inflammation. And so what we did is looked at some resection margins, and we did find interleukin-1 beta in the resection margins. So we know it's there, meaning when we take some bowel out, if we look at the edges and we assay it, we know that this inflammatory mediator is there. And it's more in the horses that went on to reflux, at least in the proximal resection side. So we know it's there, and we know it's more so in those horses that went on to reflux. And so the model that we created to test this out was by taking horse intestine and then retrieving the enterocytes from the inside of the bowel and culturing them. And so then this is a cultured dish of equine enterocytes. So it's like looking at the lining of the gut, but in vitro. And then the other thing that we did is we harvested the glia. And this publication down here explains how to do that. But it involves dissecting the layers of the bowel and then ultimately getting down to just the enteric nervous system part of the intestine and snipping that up and then digesting it to culture out the glia. And so these arrows point to these glial cells, which have got these long prongs on them that help them interact with other parts of the nervous system. And we know that they're glial cells because we can stain them with specific stains. So this is a nuclear stain. This is glial fibrillary acidic protein. And then when you overlay the two, the purple areas are where the nucleus is overlaying with this GFAP. So we know that they're glial cells. And then we can put the two together in culture and actually culture them and measure the resistance of the monolayer. And so if it opens up and becomes more leaky, the chart here will show a lower reading. And so what we know is that interleukin-1 beta treated glia placed onto enterocytes in co-culture significantly reduce the resistance or the leakiness of the bowel. And it was not that much more different whether it was 10 nanograms or 25 nanograms of interleukin-1 beta. So again, the interleukin-1 beta interacts with the glia, they interact with the enterocyte, they make it leak, and then the thought is that'll create more inflammation throughout the bowel, which may be more problematic. And then if we put in serum here to try to block it. So this is serum alone, interestingly, actually increases the kind of resistance of the monolayer of the interior lining of the bowel. When we include serum with the glia and the 25 nanograms of IL-1 beta, it actually helps to partially prevent the drop in or the leakiness that we see in that enterocyte monolayer. So serum, when you inject it into the bowel, or put it on this in this co-culture system, will partially reduce the level of inflammation. And so it's just a potential future therapeutic idea for reducing inflammation in the bowel. It's not something we do in the clinic yet. So the current evidence and future directions we have right now, I've mentioned that we know that obstruction, ischemia, and manipulation trigger inflammation, which can trigger a postoperative ileus. There is evidence for lidocaine reducing both inflammation and ileus, so we are presently using that medication. I showed just now in those slides that enteric glia exposed to interleukin-1 beta, which we know is there in the bowel, does trigger reductions in what we would call epithelial barrier function, but it makes it leak more, and that may trigger ileus. And there's a lot more work to do there. And then we have a lot more work to try to understand the signaling between the epithelium, the enteric nervous system, including the glia, to try to get a better understanding of this postoperative complication. And then just as an idea for the future, we've shown that if you introduce serum into the co-culture model, and then potentially if you inject it into the bowel, you would do that, by the way, after it's been emptied and before you're ready to put it back in the horse. It might block this inflammation. And the idea is a little bit like the use of the interleukin-1 receptor antagonist protein that we use in equine orthopedics to block IL-1 beta. And as I mentioned, we're not doing this currently in the clinic, but it is something that we're looking at. And this one other thing I just wanted to show, because this is a nutritional conference. This particular paper doesn't mention it in the title, but one of the things that was mentioned earlier and is important is when the horse stops refluxing, as soon as they stop refluxing, early refeeding is shown to be really important. In this case, they're using a concentrate, but typically we would early refeed with small amounts of very high quality forage to try to stimulate motility. So you sort of have to think about this from the complexity of postoperative ileus, but sometimes the simplicity of the horse is it just needs to be refed to get things going again. So take-home points, this is an important prevalent complication associated with small intestinal obstruction and shock. Need to decompress the stomach, appropriate fluid therapy, early refeeding, non-steroidal anti-inflammatories, and then lidocaine with further studies coming. And from that, we hope to get a happy, healthy horse at the end of a colic surgery like this one. And I'd be happy to take any questions.